Hello, everyone. As you're coming in, we'll give people kind of a couple minutes just to get settled. Just so everyone's aware, like you're welcome to keep your video on. You can turn your video off. We're going to keep the microphones muted throughout, but if anyone wants to maybe ask something a little bit more personal in the chat or anything, you can change your name if you want to remain anonymous. But if not, we'll just have some chats as needed, or we can just hang out while the presentation happens. Probably give people just like 2 more minutes to come in. Those stragglers.
Are we supposed to see a full screen?
Yes. What are you seeing?
I'm seeing one, two, three, four smaller pictures at the top. And the
You
date,
can't see my screen?
I can see you. Yeah, you're one of four at the top.
But you can't see my presentation?
No.
No.
Hmm.
See, what is pelvic floor, pelvic height?
Yes.
And that's it.
Okay. Like if I change this, did it change slides?
Yes, it did.
Yes.
Okay, perfect. That's what you need to see. That's the important bit.
Okay.
Excellent.
You may.
All right, for any newcomers in here, if you don't mind just making sure that you're muted. We'll kind of stay muted throughout. We're going to use the chat. So if anyone has any questions at any point, please put it into the chat. And then we'll be able to kind of pick them up as soon as possible from there. But if I'm completely ignoring you, please put your microphone on. But otherwise, try to stay muted just so we're not accidentally interrupting each other as we go. All right. I think we're going to get going. And then if anyone else kind of comes along, they can just join in where we are. Firstly, my name is Ellen Wedemire. I am a pelvic floor and a quote unquote normal physiotherapist. So I work on pelvic floors and I also work on shoulders, but really pelvic floor is where my passion lies. As we go through the presentation, you'll see this is where my passion lies. So sometimes I can start talking a little bit fast. So I'm going to have Renee, our lovely Renee, let me know if I'm talking too quickly. And also if there's anyone asking questions in the chat. So please don't be afraid to ask questions as we go. And I'll try to answer them as we go, or might decide that we're going to answer them at the end as well. Just kind of whatever is going with our presentation. All right. So in kind of my experience as a pelvic floor physio, what I've really realized is that people just simply don't know that pelvic floor is an option or have no idea what it entails. And oftentimes, what I see is people come to see me after their mom went, and then their sister went, and then their doctor told them. And then finally, they're like, okay, fine, something must be happening in this world. And I think a lot of that is just that we simply don't know what it is. And it's such a mysterious thing, and mysterious things can be really disconcerting or kind of bring up caution. So, what I really wanted to do with this presentation is just let people know what it is we do, who we can help, what conditions we can help, what does a treatment look like, what does an assessment look like, just to kind of take it out of the gray area and allow people to be really confident knowing if it's going to help them and what it could entail. So let's get started. Big question. What is pelvic floor physiotherapy? So throughout the presentation, PT is always going to mean physiotherapy. I don't think I ever do it, but if I ever go PF, PT, pelvic floor physiotherapy. And really, it's a subset of physio that really focuses on the muscles that are kind of on the bottom of the pelvis. They create a bowl on the bottom of the pelvis. But it's not only those muscles, it's the surrounding area as well. So we're looking at the hips, the inner thighs, the thighs in general, so quads and hamstrings, up into the abdominal wall, into the back as well. And the big reason that we have to look at all of that is because everything is an interplay, and we'll get a little bit further into that in a moment, but also the pelvic floor is part of the core. We hear core very frequently. Everyone knows we're supposed to have a strong core, but most people think of abs when we think of core, but that's not actually what the core is. And we'll get into that in a minute as well. So we as pelvic floor physios we have just special training, extra training in all of those areas and the conditions that affect all of those areas. And the most important question is who can be a pelvic floor physio? Because it can be very intimate. We can do internal assessments. So it's important that you know who is actually treating you. And the way that it works is you have to become a physiotherapist first. So you're doing your undergraduate degree, you're doing your master's in physiotherapy as well. And then once you are a physiotherapist, then you can do postgraduate training. So anyone who wants to be like a internal assessment pelvic floor physio has to be trained in internal assessments. And what that means is we have to have just an intimate knowledge, a really intense knowledge of that pelvic floor musculature and what it feels like to actually go through an internal assessment. And we'll talk about that assessment a little bit later, but know that anyone who is conducting an internal assessment has been trained specifically in that. There's a few different ways you can be trained in the pelvic floor world in Canada. I have a lot of training through a company called Pelvic Health Solutions, but there's a whole bunch of different ones. And I've been, training from pelvic floors in physios in the States and all over the world, really. But a lot of places, their level 1 is going to be regarding their incontinence, prolapse, and just pelvic floor in general, and that internal assessment. Then you get to fly free. So every single pelvic floor physio in Calgary, for example, is going to have slightly different training. We're all going to have similar training in the basics, in the incontinence, in the prolapse kind of, but how to do an actual assessment. Then we get to kind of choose what we want to know from there. And that's all further courses. And so, for example, for me, I then took courses in pain and the trauma response. So all the different pain conditions in the pelvic floor, as well as how trauma and mental health and kind of past history all affect those, and how we treat not only the tissue, but the entire nervous system as well. I also have training in cesarean section rehab and labor and delivery for a vaginal birth and postpartum rehab in those worlds. There's extra training in a lot of core, as you're going to see, very important. There's different ones for special needling or acupuncture in those areas. There's courses on visceral work, which is like organ work through there. I don't have that one yet, but there's so many different things, and that allows each physio to really find what they're passionate about and the clientele that they tend to work with, and actually get the knowledge for that. So I think it's just really important that people know how we got our certifications and that we are legally being monitored by our colleges as well, because it is and can be a very intimate thing. So more on the pelvic floor. The pelvic floor, like I said, it's like a bowl at the bottom of the pelvis, but we don't just have muscles that are inside. We have muscles that are outside as well. So we're going to have ones that are kind of on a diagonal that start up on the pubic bone. So this picture on the left side is as if I was looking at you. If your head was away from me and pelvic floor is facing me, that's what we're looking at. So we have the pubic bone on the top, and this is our tailbone on the bottom. And so the muscles that go on a diagonal off the pubic bone, there's muscles that go straight across. This is a female pelvis. And so we have muscles that are split along and under our labia. In a male pelvis, that muscle is actually connected and it sits under the scrotum. So those muscles are actually external and we can palpate them without having to go internal in any way. And so those guys are really helping to support from the bottom, especially in males. Those muscles can really help with continence and the ability to achieve an erection. So those are really important muscles as well. Then we have the internal muscles, and we have a whole bunch of them that all work together to both squeeze and lift to help us remain continent, to help us be able to support our organs as well. We'll have a better picture on that in a moment. And so they're all really working together. Again, this is a female pelvis. So we have muscles that will wrap around the rectum. That helps us remain continent for the bowels, which is very important. We have muscles that wrap around in this female pelvis. That is going to be right around the vaginal canal and the urethra. Very important for bladder continence. We have many muscles that attach to different areas of the pelvis. So we have the pubic bone on the front. We have these guys that attach onto the sides of the pelvis. And this is the tailbone. And that's really important because some people have chronic tailbone pain and can't figure out why. And most of the time, it's actually tension in these muscles that attach to the tailbone, the same way we can get shoulder pain when we have tension in shoulder muscles. So it's really nice to kind of have that visual of the pelvic floor because it's not just one muscle. There's a lot going on in there. And there's many conditions that can arise when one or more of those muscles goes awry, goes away from the plan. You can also see this is from the side that it's a really important hammock. So in the female pelvis, we have our bladder right in front. Directly behind it is the uterus and the vagina here, which looks very thin, but is very stretchy. It's kind of like a balloon. And then the rectum right behind, so the intestine leading to the rectum. When we have a nice, strong, and functional pelvic floor, that helps everyone to stay where they're supposed to be. It helps to kind of support everything and helps the closure of the anus, of the vagina, and of the urethra. In the male pelvis, same thing. We don't have things as close together, but we also have a prostate that's hanging out just above that pelvic floor. So we can have some interplay between pelvic floor muscles and the prostate and the urethra that's really, really long. And we need to be able to maintain continence in multiple different areas along the way. So that's kind of a side view of that nice bowl that's sitting at the bottom. So that whole area is considered the pelvic floor. We also have the interplay between the pelvic floor, the diaphragm, which is our breathing muscle, our abdominal wall on the front, and it's really just a very deep muscle called transverse abdominis. So it's not your six-pack muscles or the cool ones that go down on the side called the obliques. It's very, very deep muscle that kind of wraps around, and then little tiny, tiny back muscles that are along the spine. That is our core. It's not just our abs. That is our core. And the way that we are designed is actually that when we inhale, the diaphragm that's right on top, you can see it in this picture right on top. As we inhale, it should come down. As it comes down, it's going to create really nice pressure in the abdomen, which is going to allow it to expand outwards. And as that happens, the pelvic floor is supposed to lengthen and drop down and be that nice bowl. Then as we exhale, we are designed for that diaphragm to come back up, which is going to allow that pelvic floor to come up, have a gentle contraction that we shouldn't feel, but that allows us to maintain proper pressure in that abdomen, engage a bunch of core muscles, and help us stay upright and help us engage that core. So the diaphragm and pelvic floor connection, the way that it kind of works as a piston back and forth, is imperative for many things, such as core engagement, back pain, hip pain, anything like that can be related back to this, and our ability to actually fully relax the pelvic floor and fully strengthen it or use it throughout the day. So it's nice to kind of see how the pelvic floor has interplay in those different muscles and how the function of our day to day can be affected by it. So when we think of pelvic floor physiotherapy, that's that PFPT, it can help so many different conditions. And it's because there are so many different things that can happen in that pelvic region. The one that most people know about or think about is going to be incontinence. That is going to be anytime we leak our bladder or our bowels before we want to. So anytime we have any leakage before we are firmly planted on the toilet. There's two main types of incontinence of the bladder. We have stress incontinence, which is the one most people think of. That's your coughing, sneezing, laughing, running, jumping, trampolines. That's a big stress incontinence kind of situation. And then we have urge urinary incontinence, which is related to urgency, which is right below. Now, urgency is different. When we just have straight incontinence, there's a decent chance that it's going to be because of pelvic floor weakness or just the inability to connect to that pelvic floor. When we have something like urgency, which is the phenomenon where you are fine, and then all of a sudden you have to pee right now. Oftentimes it's connected to something. So maybe it's like when you get home, you put the key in the door and then you're like doing the potty dance because you have to pee so bad right away. Or for some people, it's when they hear water, or if they leave the house, they have to pee like 2 minutes later, any kind of connection. Urgency tends to be related to tension of those muscles. So sometimes we can have an urge urinary incontinence, which means you get crazy urgency, you're running to the bathroom, and then on the way, we get a few little dribbles. Oftentimes that means that we have tension that's either restricting our ability to use our muscles, or we have a little bit of weakness in those muscles as well. So both of those, very pelvic floor related, two different causes usually. And that's why we don't just want to be Kegels all over the place, because if you are very tight and you're just doing a bunch of Kegels, number one, you're not going to solve your problem. And number two, you might make it worse. And we don't want to be doing that. So incontinence and urgency, as well as urge incontinence, are the ones that we tend to see the most. What we can also see is frequency. And I think everyone has someone in their life like this where it seems like they pee every hour or more, especially if you go on a road trip with them. And frequency, as well as urgency, can have a big brain bladder component to it. So oftentimes we accidentally train ourselves incorrectly. So if you are constantly peeing every single time you leave the house, even if you don't have to, you're training your brain that the bladder is not actually able to fill up quite as much as it actually can, which is really interesting. And so when it comes to something like frequency, treatment's a little bit different. Oftentimes there's going to be a tension component as well, but then you're training your bladder to learn what it's like to actually fill up, which is kind of cool. Other conditions, pelvic organ prolapse. This could be bladder prolapse, uterine prolapse. It can be a rectal prolapse into the vagina, not out of the anus. And all of those prolapses, all it means is that an organ is traveling to an area that it's not supposed to be. And generally it means that it's pushing on the vaginal wall and coming into the vaginal space. For some that are a little bit more progressed, it could mean, that an organ is coming right to the vaginal opening, for example. Much more common in women. You can have a little bit of prolapse in men, but we don't see it as often because they don't have that vaginal opening to kind of let them know things are happening. With prolapse, there is a lot of importance in getting some sort of help because we can try to, number one, reduce the likelihood that it progresses and gets worse. But also, if it is bad and you do require surgery, it's important that you know why it happened in the first place. And if it's a pressure issue, if you're constantly pushing down and it's pushing your bladder down, and you get surgery, but you don't change why it happened, you're going to push the bladder down again. And there increases the risk of it not being successful. And I don't want that for anyone. Okay. Almost as often as I see incontinence patients, we see pain patients. And this is incredibly common, but people don't tend to talk about it. And this is any kind of pelvic region pain. It could be pain that you have all the time, just at rest all the time. It could be vaginal, it could be pubic bone, tailbone, kind of deep hips, any kind of low back pain that's super, super long standing, that you've done a bunch of stuff and nothing's helping. Sometimes it can be pelvic floor related. We can also have pain just with positions or with certain movements as well. You might only get pain when you're running or when you lie in a certain position. And all of that can generally be sorted out as long as the treatment is appropriate. What we can also see is you be completely fine, but then anytime you are touched in that area, there's a lot of pain. So that could be sexual touch, but it could also be clothing. It could be when you're sitting and have pressure against the labia, for example, or against your sit bones, that causes pain, or the tailbone, which is no fun. Or like I said, certain movement, and pain with penetration. Pain with penetration is never normal. And that's important for people to know. There is a cause, and where there is a cause, there is usually some sort of solution. This can be with penetration that is of the sexual variety, but it could also be people that want to wear tampons and simply cannot. They have pain every time they try to insert. It could be people who are unable to, or have incredibly painful pap tests, or have to do an internal ultrasound and just physically can't get it inside. I've had multiple referrals from doctors for people who need internal assessments or internal ultrasounds, and it just simply is impossible. And so that's usually tension related, and you can start to down regulate that, regulate that from there. Other things, sexual dysfunction, that could be erectile dysfunction. It could be inability to climax as well. Post-operative, anytime you have an organ removed from your abdomen or pelvic region, a lot of stuff happens in that area. And oftentimes we'll see the abdominal wall and or the pelvic floor really, really tighten up. And so oftentimes we can just kind of help that rehab process, or help you to engage that core again properly. Prostate surgery, and you'll see that in the oncological issues. Anytime someone loses their prostate or has any kind of removal of the prostate, then it can really increase the chance of incontinence or erectile dysfunction. And we know through lots of research that doing exercises prior to the surgery and then directly after significantly decreases the risk of both of those things. Hernias are because you have the wrong pressure system. And so you need to be able to change that pressure system, whether you want to just work it conservatively, or if you have surgery to help make sure it doesn't happen again. Then comes babies. There is so much that can be done prenatally, even preconception, but prenatally to prepare for birth, to allow birth to be significantly smoother, to allow the postpartum experience to be significantly smoother. I have a few talks on those things, and it is incredible what a confident woman can do. And so I highly recommend anyone who is pregnant to see some sort of pelvic floor physio, just to have an idea of what their body is doing, to be able to learn what a closed pelvic floor versus a nice open pelvic floor feels like, to feel what it's like to push properly, and to make plans for postpartum, whether or not it is a vaginal or cesarean birth. You can prep beautifully for both of those, and you can recover beautifully from both of those. They're just a little bit different. Oncological, like I said, any kind of cancers in the area, we help, we treat. Obviously, we can't treat the cancer itself, but we can look at the side effects that can happen not only from cancer, but also treatment, and how can we help the recovery process from there. Last two, chronic constipation. Lots of people don't realize pelvic floor tension can be the cause of that. So for those that have done everything, have been tested for everything, have done all of the assessments and still can't figure it out, sometimes it is a pelvic floor tension issue. And so releasing that can help things move along a little bit better. And any kind of pelvic trauma. The pelvis, especially the pelvis, the body in general, but especially the pelvis, remembers trauma, whether that is a physical trauma of just you fell and fractured your tailbone, or if it is an assault or an attack trauma, whether it is emotional abuse. A lot of things can affect the pelvic floor, and there's a lot of things that you can do to downregulate that as well. So if any of those things are happening and you're like, I think I need to go see a pelvic floor physio, what does the assessment look like? Firstly, there's intake forms. And now every pelvic floor physio is going to be a little bit different. Some people just have really short forms. I have incredibly long forms, and I apologize for that. But what that allows me to do is to gather all of that information, make sure I'm not missing anything, and then have a conversation that is tailored directly to you. So The way I ask for it is that it's like a 15-page long intake form. It's outrageous, but it is going to tackle everything from sexual health and sexual history, bladder health, if you've given birth, if you have a prostate, all of your prostate information, bowel information, mental health information, general activity, general health things, because all of those things can impact the pelvic floor in ways that you may not suspect. And so it's better that we get all of that information up front instead of you working incredibly hard and not getting where you want to go because we missed something. So I like to do all of that up front. Other people like to kind of get it as you go. Both of them are correct. But if you're to see me, sorry in advance for the long intake forms, but it's worth it because I also ask people to submit them beforehand so I can go through and highlight and write my notes. And that way, like I said, the conversation can be very tailored to you and your experience, and I can get more information to what is actually pertinent for your situation. Heads up, if you do see me, those forms get personal very quickly. But as long as everyone knows, if you come to Active Sports Therapy and you submit your forms, the rule is, and the entire front staff knows this, and they are wonderful and very respectful, the front page gets scanned in or attached to your digital file within the clinic because the rest of the clinic is it's digital, it's online. But the rest of it either gets printed off immediately, or if you submitted it in person, it doesn't get looked at all. It goes into a paper file so that everything is completely confidential and it's for my eyes only. Like to let people know because it does get personal very quickly. Okay. Then for the actual assessment, I've already got those intake forms. I've already looked through them. So now we have our conversation, and we are going to take as much time as needed because all of this information is so important, as I mentioned. And that's why assessments are always longer. I know I like to keep mine to 1 hour and 20 minutes because an hour just simply isn't enough. And it allows me to have a longer conversation if necessary. It might not be necessary, and that's okay. Then we have more time to do physical assessment from there. But always know that the conversation is just as important as any kind of touch or exercise or anything like that, because there's so much education and connections that can be made before we even start the assessment. Then we have the assessment. And for many people, we actually start away from your standard internal pelvic floor assessment. We start externally. And so we may be looking at posture, mobility of different areas, definitely breathing patterns, because like I said, diaphragm, pelvic floor, very important relationship. And so we'll be teaching breathing immediately because it's going to be used throughout the rest of your treatment plan. May also be looking at hip mobility, hip strength, back mobility and strength, ability to engage core. If you have any scars in through abdomen, perineal region, definitely checking those out because those can tug and pull and affect things. Maybe looking at how you can engage your abs versus your core. There are so many different things that we can be looking at. So it's important that people know that if they are uncomfortable with an internal assessment, which we'll discuss in a second, that there is so much that can be done without going internal. And that's super important because I never want the internal assessment to be the reason why someone does not pursue a solution for what they're dealing with. The other interesting thing is, especially with men, a lot of information of the pelvic floor can actually be felt externally. And so we have those external muscles that I talked about at the beginning, the ones that kind of attach to the pubic bone and come across and either sit under the labia or under the scrotum. And especially in men, we can actually feel at the base of the penis, and we can see physical movement to ensure that there's actually some sort of muscle contraction happening and the correct muscle contraction happening. We can also feel those in women. The big thing is that in men, those are the really important muscles for not only incontinence, but erectile dysfunction as well. So with anyone, when we go internal, we can go rectally. I like to avoid doing a rectal assessment just because it's not comfortable. But if there's bowel related things or we need to, by all means, we're going to. But there's so much that can be learned exclusively externally. So we can usually avoid the more uncomfortable parts, unless, of course, like I said, very necessary. Then we have the internal. And again, the internal doesn't even start internal. When we're going internal, we actually start with those external pelvic floor muscles and an assessment of the skin in the area. So we're looking for redness, thinness, weirdness, anything that seems off in that skin can be indicative of certain conditions. They're also looking at if there's pain through the pubic bone. So I'm probably going to press on the pubic bone, make sure that everything's hunky-dory through there, and feeling along the inner thighs, because the inner thigh muscles called the adductors, they attach onto the pubic bone. So they're really important as well. So there's a lot of stuff, even though you are undressed, that we are going to look at first. And on that note, what it looks like is when we're doing the internal, you just lying on, it's a physio bed. It's just like any other physio bed you'd get elsewhere. And it just has some paper on it. It has a pad that you would be underwear and pants off. So your bum is going to go on the pad and you're going to be lying on your back as hopefully as comfortable as possible. Nice sheet over top to make sure that you are completely draped and as covered as you are comfortable with. And so that would happen. We do a nice check of the skin of the whole area. Then, if it's appropriate and necessary, we can do the internal component. And what's really important is to know that there are no tools involved. The only tools are either 1 or 2 fingers with a lot of lubricant on it. So when we're looking at tension, which is the first thing we would assess internally, it's just going to be 1 finger. Lots of lubricant, like I said, and we're going to insert into the vaginal canal. Again, this can be rectally, but vaginal if we have it. And then just gentle rotation and a little bit of pressure inside. That's it. All that is going to do is tell me if you have tension, because we can feel muscles that are tense feel different than muscles that are loose and happy. And you're going to know if it's tender as well. And it's just the gentlest, nicest little pressure. It's not this intense digging or anything like that. And it's just going to be a little bit of pressure. If you have tenderness or I'm feeling any tension, all we do to treat it is I maintain that pressure and you breathe with your diaphragm. That's it. That's all we need to do because of that beautiful connection between the diaphragm and the pelvic floor. We don't need to be massaging around or being intense. We just need a little bit of the pressure to connect to the brain so that that can relax. And we'll go through and try to feel all of those different muscles on the inside. You can usually feel it with either 6 or 7 spots on each side. And we'll do one side, all of them, and then the other side so that there's the least amount of kind of movement in there. We always check tension before we check strength. And that is because muscles that are tense are already slightly overlapped. So the way that a muscle contraction works is one fiber overlaps onto another fiber, and that creates power. And so muscles that are tense are already halfway or 3/4 overlapped. So we don't have a lot of room to create power. So I am never going to assess strength if there's tension because it's just going to give us a false, unfortunate reading and we're all going to be frustrated. So we always feel for tension first and then treat it before we start moving on. Then, if there wasn't any tension or it was a quick little treatment, we check for the muscle contraction, which is the thing that you're all thinking about if you know what an internal is. And that is your Kegel. We're trying to assess your Kegel. And that is with 2 fingers preferably, so that I can feel the closure and the left versus the right, because we want those to be nice and equal, and sometimes they're not. In that, I'm also going to be feeling what the front of the pelvic floor is doing, what the back of the pelvic floor is doing, what the deep pelvic floor is doing versus the more superficial. If there's coordination issues, if you can get it, but you can't hold it. There's so many things about the quality of your Kegel, as well as the strength, that is going to tell us what the heck is going on. And oftentimes, it's not necessarily a strength issue. It's more of a coordination issue. It's more that you're only using the back of the pelvic floor, not the front, but the bladder sits at the front. And sometimes if we can just kind of get that turned on and you can find that area, then we are rolling. And that can sometimes be over just a few treatments, which is really cool. So we always want to assess that muscle contraction if there's any suspicion that that could be involved. And that is just 2 fingers. Then, if there is a suspicion that you have prolapse, we can assess what we call vaginal wall weakness. So basically, we're seeing if that bladder or the uterus or the rectum are kind of pushing on the vaginal walls or coming into that vaginal space. And then determining if that could potentially be what's causing your symptoms and what next steps could be. Could be exercises, could be what we call a pessary, which is like a little splint that you put up there. So if we think that that could be related, then definitely assessing for that weakness as well. Other assessments are really important and they tend to come a little bit later on. They could happen on day one, but we're probably going to look at functional things. If you're an athlete, then it's amazing if you can do Kegels while you're on your back. But I need to know that your pelvic floor is going to work when you're running. And so we're looking at things like how do you squat? How do you lunge? If you do a single leg squat, are your hips engaging properly? Are you able to get out of a chair evenly? Are you able to hop or jump without any leakage? Or looking at you, maybe there's a biomechanical reason that that's happening. There's also things like the abdominal wall, which we could look after. Diastasis is, for lack of a better word, separation. I don't like that word, but it's where we have space between our six-pack abs, frequently after pregnancy, but can happen to anyone. And those are specific assessments as well. So a lot of more functional things, kind of looking at how everything else is tying together. And it's important that you know that assessments happen throughout your treatment process. We're constantly assessing and reassessing and making sure that we're moving towards the more functional side of things. So we assessed, we got all of our information. We know that maybe you have a little bit of tension on the left side of your pelvic floor. Maybe you're using the more superficial pelvic floor, not the deep pelvic floor, or the front and not the back, or vice versa. Then we decide the appropriate treatments. So generally, if you're more on the tension side, if you have pain, almost always, we're going to be looking at relaxing or down regulating the pelvic floor. And that is going to be number one, connecting with your breath, especially your inhale, and that ability to actually let go through that pelvic floor. So we're going to do the manual release with the finger, like I said, but you're also going to be taking the breathing home and adding some pelvic floor stretches into the mix, things like cat cows and child's pose, things that you've probably seen before. And we just make them very pelvic floor specific and pair with the breathing. We may also, if we have to relax the pelvic floor, use a Kegel and the ability to actually fully relax from there to get that coordination component as well. So pelvic floor relaxation, super common as a treatment plan. There's a reason I thought of it first and put it first. I think I do that more often than just strictly strengthening. But when we do think of strengthening, we need to think of the pelvic floor the same way we think of any other muscle group. So we need to get strength and endurance and power. And power is strength under time. So we are doing short holds for strength. We're doing long holds for endurance. We're doing what we call quick flicks, which are just kind of rapid contract and relaxes for power. We're going to be looking at maybe just isolating part of the pelvic floor, which is a bit of an adventure, but everyone can do it. And just finding that coordination. And then if we can just get the front, bringing it back into that full pelvic floor contraction. And now can we do it in a more balanced way? We're also going to be progressing from lying down to sitting to standing, because if anyone here has any leakage, you'll know it's way more common when you're standing. So we need to make sure that, yes, we lie down first because then we can isolate it and it's a little bit easier. But eventually we need to progress to standing so that your body actually gets to practice what it needs to do. And then we do functional stuff. Now we're adding the pelvic floor to the ability to sit to stand. We're adding it to squats and lunges and walking, or if you're a runner, getting back to running. Maybe we're adding it to your routine that you're already doing. Maybe we take the yoga or Pilates class that you're already doing and finding ways to connect to that pelvic floor so that the brain knows that it can use the pelvic floor whenever it needs to. So we always want to get to some sort of functional movement. Other things that we might be doing: hip strengthening, Hip and glute strength is directly correlated to pelvic floor strength. So if we have weakness throughout the hips and glutes, oftentimes we'll see weakness in the pelvic floor. And sometimes just simply by strengthening those, we can see pelvic floor increase, which is awesome. Likely doing some sort of rib cage or pelvic mobility so that we can actually stack the diaphragm and the pelvic floor so you can use it as that nice piston. You might be doing core strengthening, abdominal wall, coordination or strengthening. There might be some just strictly manual work. We might just be working out your hips or your abs. We could do that with my fingers. We could do skin rolling. We could be doing cupping. We could be doing scar massage if you have a scar anywhere. Also, a lot of nervous system stuff. In the case of things like frequency or urgency, oftentimes we're doing some sort of bladder retraining and teaching the bladder what it feels like to actually be full versus halfway full. Urge delay is exactly what it sounds like, teaching the brain to be able to delay when we get that initial urge. Maybe we're going over toilet positioning, especially squatty potties. Highly recommend squatty potties. Bladder irritants, if that may be pertaining to you. If you're in for a very specific reason, which most people are, for example, if you're a pregnant woman, we're going to do lots of education on labor and delivery, postpartum, all of that. If you are in for a tailbone issue, then maybe we're going over sitting positions and how to transition between movements with less pain. There's so many different education points where truly we could just have a conversation for an hour and you can probably start to do things differently at home without me even touching you. There's just so much that I wish the general public knew, and this is the best we can do, is try to disseminate information like this. Treatment plans are really interesting in the pelvic floor world because they're different than a normal physio treatment plan. If you sprain your ankle or have a rotator cuff injury or you throw out your back or anything like that, there's a good chance that your practitioner is going to want to see you twice a week, possibly 3 times a week, depending on your injury. When it comes to pelvic floor, generally maximum once a week. The average, at least for me and for other physios that I've spoken with, is every 2 weeks. So oftentimes you'll come in for the assessment, depending on how things are going, maybe you come back the next week, especially if there's tension that we need to release again, maybe you come back the next week again. But from there, it's every 2 weeks, then maybe 3 weeks, then maybe a month, and then maybe we're checking in after a couple months. A lot of it is homework based. And it's because you're training your nervous system, you're learning how to connect with your pelvic floor, and you don't need to be in clinic to do that. Really, what it's like is that I'm the coach. So I'm going to teach you the knowledge that you need, and we're going to practice. We're going to make sure that you're doing it correctly. And then you have to go home and you just get your reps in, you figure it out or not. And then we come back together and figure out what worked, what didn't, what can we progress, what do we have to pull back, adding, subtracting, kind of dependent really on your situation. But that is how it's going to look. So it's not going to be this situation where you're coming in 3 times a week. It's oftentimes every 2 weeks. And for most people, I'd say 6 to 8 treatments is kind of average. Some people it's longer, it depends on your situation. But sometimes it's less. Sometimes I'll see people like 4 times and then we are rolling. And it all depends on kind of what your condition is. When it comes to labor and delivery, it's a little bit different. Those are specific times. I like to see people kind of mid 20s, around like 26, 27 weeks, 30 weeks, 33 weeks, 36 weeks. Sometimes we add more depending on what your situation is, but generally we're doing specific training at those different weeks. So that tends to have a relatively specific timeline that we can kind of change based on the situation. But everyone else, it's totally dependent on your situation, what it looks like. But the rule is that we always try to be in the clinic the least amount of times possible and doing the most at home if you can. Sometimes I have some people, and I love it, that might come in just for a check-in every 6 months or every year, kind of like your annual checkup, just to make sure nothing has changed or to make sure that the Kegels still feel right, to make sure that there isn't any tension built up. I know I go and see a pelvic floor physio about every year because sometimes I don't know that my tension has increased. So it's nice to kind of get that feedback as well. So it all depends on your situation, what you're dealing with, what you're comfortable with, but know that this is not a 3 times a week kind of treatment plan. Now, obviously, I kind of skimmed over a whole bunch of different conditions and I could talk forever on all of them. And so, thankfully, I have done a bunch of previous presentations on those specific things. And those guys are up on YouTube, which is thankfully very public. Our clinic page is Active Sports Therapy 1. There's the numeral 1. And I have done a presentation specifically on prolapse, on incontinence, on the pelvic floor and the low back connection. That's going to be a lot of core stuff, on the trauma connection with pain and with how the pelvic floor reacts, specifically pain with any kind of insertion, why it happens, what can be done about it, the bowel relationship with not only the pelvic floor, but incontinence as well. And then I did 3 on the different stages of basically pregnancy, postpartum, and then returning back to activity and sport. If you are interested in any way on more information on any of those, please go and look at these. There's going to be an email sent to all of you tomorrow, I believe. And there's going to be a link to every single one of those in that email. So I obviously am very happy to answer any questions, but if you're still wondering what something might be or what a treatment might look like for a specific condition or why it could be happening, there may be some answers in that as well. So please, if you have watched those or haven't, whatever works, if you have any questions, and obviously we'll open up to questions in a moment here, but if you are more comfortable emailing me directly, my email is simply ellen@activesportstherapy.ca, and that will be put in the email as well if we can, Renee. Please, I am more than happy to answer some questions. Obviously, some questions can't be answered if I feel like I need to assess something. But if there's little things like I'm not sure if I'm appropriate for this, I also do 20-minute consults, whether that's coming into the clinic or over the phone, where we can just quickly chat and kind of determine if this is something that can be helped with pelvic floor physio or if I have special training or whatever it is. Really, my biggest goal is just for people to understand that they don't have to live with a lot of these conditions. There is no such thing as normal leakage. There is no such thing as normal pelvic pain. And there are so many things that can be done. And I want people to feel comfortable and confident finding the appropriate pathway to solve those problems. So if that takes an email to me, I'm happy to answer that. Any of the like just free consults so we can have a little bit of a chat, happy to do that, to just figure out what your kind of best situation is going to be. If you have anyone in your life that you're like, hey, you pee every 30 minutes, maybe send them along a presentation or give them my email. Let me help the people that you love as well, or any other pelvic physio. There's a lot of us out there and we just want to help and we want people to know that there can be help out there. Okay, any questions from here?
Hi, Ellen. I'm not seeing any in the chat box at the moment.
Sounds good.
I'll give you an update there.
Sounds good. That's a lot of information in a very little amount of time. So brains are probably just like trying to digest it all, if they're anything like my brains.
Thank you.
You're so welcome.
Yeah, it was great, very informative. Probably will be communicating with you further, but thank you so much for putting this together.
I am so happy that you're here and look forward to meeting you or talking to you.
Just so you know, I'm just Simone, not Simon, though.
Got it. I'll look for Simone.
So
That's
good.
funny.
Yeah.
All right.
Hey, if we don't have any questions, be sure to check your inbox tomorrow with a playback for this video. It will be live on YouTube, as Ellen said, along with all the other videos that Ellen has put together throughout the years. Thank you so much for your time, and thank you, Ellen. Your information is always very much valued, and the passion in what you do is there.
Can't hide it.
Okay,
Thank you everyone for being here.
thank you. We wish everyone a great night. Bye for now.